He has some things to do, but he's here with us. He's listening to the talk. We are here now in our hybrid classroom. You're gonna see what's going on here, what's gonna happen. Luz Marina, thank you for being here. Takashi is getting ready in Brasilia. So we're gonna start, okay? The first thing for today is to thank you for your time, and second, for you to understand what's going on here. As you saw the week before, we are in our physical campus, but this is not a typical campus. This is a completely hybrid campus. And what it means is we have students here, amazing friends and colleagues who are learning. You can see them there, they're learning their first skills in cataract surgery. And, they're going to have, they had yesterday, some tasks to do online. So that was, the virtual side of education. And now we're in the hybrid classroom where I'm going to be teaching interesting concepts, and they're going to be learning and training. Then, if you can follow me very quick, we're going to be in the consults, because today we're going to talk about capsular rhexis in the beginning, and then Takashi is going to talk about techniques. Everything happens. There you can, prepare yourself for surgery. And after we prepare for surgery, we're going to go to surgery. Here, after they prepare those, they're going to get specialties and work. Today we have two important things. Let's talk about it. Okay, guys. So as you can see in both techniques, we're in the campus, and the first thing we're going to do, we tend to do things differently, and today, of course, is no exception, right? So the first thing we're going to do today is the hybrid blended education. What I was talking about. First, they did something virtual. Then we're going to be here in an ecosystem of learning, of deconstructing tasks and learning basic principles. And then we're going to go to surgery. This is our dream become true, but it's very important for you to understand that we don't want something completely detached from virtual to the actual, hands-on activity in the campus. So virtual and on-site are blended, as you can see there. It's a completely integrated experience. And so you can understand what happened yesterday and today is they had a virtual class. They had a virtual class they needed to do. Then we are right now in the hybrid classroom, as you're going to see. We're going to go to the consults. We're going to go to the OR. We're going to do some debriefing, guys. Today we're going to talk about all those concepts about simulation. It's going to be very important. And then we're going to do a follow-up with them. We need to understand what did they learn, what was hard, so they can, become better. So the first thing, and this is one of my favorite things, and I need to talk about a very good friend here, Dr. Andres Bernal, right, has this amazing concept about the forgotten basics, because he's an engineer, and when he sees a capsular rhexis, he doesn't understand why doctors, they don't use certain skills or certain awareness, especially in the womb. So we're going to go to the students right now, and we're going to talk about 3 extremely important things in capsular rhexis. We're going to talk about hand position, and we're going to come back to this concept. We're going to talk about floating. You guys, you're the students, listen to this, okay? Hand position, floating, and pivoting. These are 3 important concepts, and we're going to see them practicing and learning, and we're going to interact with them. So Rafa, an amazing friend too, who is giving us, an amazing help in surgery, just try to come to me, and please, I'm going to ask you guys to do a correct incision, and then with the forceps, we're going to do a capsular rhexis. So you can start. And then we have the amazing David. David Lockington, a very good friend, excellent surgeon. David, we're talking about a syndrome, actually, about the incision. So while they're training, please tell us a little more about it.
Thanks, Ivo, and a brilliant setup. I love it. I discussed with you previously the heavy hand syndrome. So what is the heavy hand syndrome? Well, what I think is, if you imagine the keratome going in, if you push down with a heavy hand, you will collapse the wound. Paradoxically, if you lift up as you insert your keratome, the wound will not collapse. And you often see this in trainees when they're using a second instrument because the wound leaks and fluid goes out. If you think about a piano player, it is possible to play the keys with your fingers straight, but actually if you get your wrist high and come from above, it stops that heavy hand pushing down. So just by lifting up as you insert your keratome, you will avoid the heavy hand syndrome, avoid leak, and avoid distortion. So hopefully that's helpful.
Now you can talk. You can talk with no problem, David.
Did you hear what I said about heavy hands?
Yes, perfectly.
Okay, so whenever you're doing your incision, as you enter with your blade, gently lift up. Don't push down, because if you push down and in, you collapse the eye. So that's avoid the heavy hand syndrome. Think about the piano player. The other thing I would say, when Ivo had on the screen the word float, your hand isn't actually floating. Your little finger is balancing on the head, and that will allow you to have the dexterity and the movement you require to do the rexus safely, or whatever movement you're trying to do. So remember, balance your hands with your little finger. That will allow you to move your hands safely. That's it, perfect.
Great. So, we're giving them instructions. As you can see there is a couple of screens. There's one here, and you can understand the hand position. He did the incision correctly, and now he's floating, and he's going to start doing the capsular rexis. Luz Marina, tell us a little bit more. You are an excellent surgeon, excellent technique to do a capsular rexis. What are your thoughts when you're teaching this step?
I also agree very much with David. You have to feel that your hands don't wait. You have to lift your hands and just move it in. Also, you have to be very careful not to press the incision at the level of the incision, because then the fluid or the OVD or things can come out, inclusive when you have the rexis and you are at that side. If you press on the incision, then you can have the rexis, a tear of the rexis that way. So you have to be very careful. I always be very aware of how to position your hands, being safe, being comfortable. Also, another important thing to say is not to hold the instruments, to grab them tight. You have to grab them easily in a soft way, such as you are holding like a pencil, very gently. Not that nobody's going to take that away from you.
Okay, perfect. So let's go back to the concepts, guys. Please stop a little bit. And now that you are actually doing, I'm going to go back to these amazing concepts David and Marina also talking about. Takashi, get ready, because I'm going to ask you too about your special secrets in capsular rexis. But let's go back to 3 important concepts about this that we call wound awareness. What happens? Sometimes even you see an expert surgeon that it will do movements that will impact the incision. So that eye is not centered anymore. If it's not centered, you're not seeing correctly, and it's also hard to to see the size of the incision on the correct vectors. So the best idea when you're in the incision is to pivot. It's to float. And to do that, you need to understand that the hand position and the hand movements are the key secret to do it. I saw you guys did a very good job in the hand position. Why? Because all the tension was in the forehead of the patient, in this case, in the model. The second thing is how you grab that forceps. Okay, you need to grab it with these two fingers and do this movement. Okay, and that will allow you to float through the incision. As David said, this is very important. If you press down, viscoelastic comes out. Viscoelastics comes out, and then the rhexis goes away. Okay, guys? If you go up, then you have stress in the cornea, and you don't see well. That's one of the key, forgotten basics. Sorry, that was the floating. Secondary to the hand position, okay? You go up, you have problems in the cornea, you go down, viscoelastic will come out. And the third thing, and very important, and we're gonna go straight to the pivoting, is I want movements from you guys outside that make movements inside the eye, but the incision will not know that you guys are there, okay? So the pivoting, and we're gonna go to that movement, will be very, very important in this case. So let's go back to the students. And Takashi, if you have a couple of minutes, please let us know about your secrets of capsular rhexis. Are you there, Takashi?
Sure. Yes.
Thank you for being here with us, Takashi. It's an honor to have you.
Thank you very much for the invitation, and congratulations for the organization. Well, I have a little, let's say, I use an ASICO forceps. It's a usual forceps, but it was designed for a 1.8 millimeters incision. So when you use this kind of forceps for a 2.2 or 2.4 millimeter incision, you have more wide maneuvers. It's more easier, to catch the capsular rhexis. And I think instruments are one of the best things that you have to know, even to measure the capsular rhexis size, right? So I have a circle here. See, when I'm not using Fento, I use this device. I put on the cornea mark, and then I know that this is 5 millimeter size. Okay, so then I can just do the sizing by the capsular rhexis by this measurement. Wow, that's the pearls and pitfalls that I would give for capsular rhexis. Okay. Ivo?
The flap. What is your preferred technique to do it?
The flap?
Yes, to do the initial flap.
Oh yeah, I think the best technique is the one you're more secure to do it. So I started to do on the 12 o'clock, then 6 o'clock, and turning right or turning left. But nowadays I start at 6 o'clock and turn to left. I was I use the first flap, from the left to right. So I prefer to do the circle left to right. That's my preference.
Perfect. David, what about you? What about you on the flap construction?
So I teach all my trainees to use the cystotome, but what I insist is that they do one incision well. Often people are timid and tentative and they go back and forward, and that causes a problem. So I would get them to go into the center of the eye, spike in the middle, pull to the left, and then pull towards themselves. So they're coming towards the main incision. And if they do that definitively, they will create a flap. they can then use the Rexus forceps to grab that flap and pull that behind the main wound. So you get the difficult bit out of the way first, and then you can go round as you wish. And I think it's important to keep an eye on the fold. You're pulling the flap, not the fold. You're keeping it flat. And at any point you get a tension line, you just let go, re-grab, and do it again. But my advice is make a definitive cut, flip it over, get behind the main wound first, get the hard bit out of the way, and then things are much easier. Remembering not to push down, because if you let viscoelastic out, your Rexus will run out.
Perfect. Luz Marina, some secrets about the flap?
Yeah, thank you, Ivo. Again, well, we do it with the spike using the capsular Rexus forceps since the beginning, just making the spike with the tip of the forceps and just moving toward 12, towards 6, and then lifting the flap, and then left hand to the left side, toward the left side, well, in a circle. Another important issue is to consider the length of not just the width of the incision, but the length. Because if the incision has too much length, it will be much harder to turn around with the Rexus, and to turn around with the flap. And if you have a smaller, if the incision is not so long, then you can move easier. And when you lift the flap, you have to do it like in a handkerchief. If you were folding a handkerchief, like placing face to face with the Rexus and moving, gently moving in a circle way to the left side. I prefer to the left side, but you can do it also to the right.
Okay. Excellent. So guys, I hope you can see them in the screens, but here we have an amazing capsular Rexus. Very, very well done. Has a very good shape. It's well centered. Maybe a little bit small. It could improve, but it was a great technique, and there was almost no stress in the wound. This stand here, and we're also doing here the capsular Rexus. It's very important now that you did it. Try to make it bigger. Try to grab it and make it bigger. There, perfect. Not stress the wound. Can you see there how the wound is stressed up? You need to have a correct hand position and float. Okay, so these fingers should be in the forehead of the patient, and you can float and you can see that there's no stress. Y hacemos lo mismo, incisión y open. Very nice. We have another amazing capsular Rexus here. Can you see it in the studio in the middle? Great technique. Almost no stress. Then again, I think it's a perfect size. I hope you guys can see it because of the intensity of the light. But it was an amazing capsular Rexus. And then we are talking about these 3 very, very, very important concepts about floating, about pivoting, about the hand position. And as you can see, if we train this without the human being, when you're faced to surgery, in a human being, and you dominate these basic skills, you're going to have such a different learning curve. It's going to be so short and so powerful that the only thing you need to understand is the correct consistency of the cornea and how the eye of the patient will move. That's very important too. So we have a fixed eye now, but with the patient, you will have an eye that will move if you do a lot of stress. So, there's a lot of things. I would like to ask the panel, starting with David, then Luz Marina and Takashi, if you are used to fixate the eye with another second instrument, or you only just float through the incision. David, what do you do?
So I don't fixate the eye with another instrument, but again, we're getting ahead of ourselves. You need to decide at the start, is this a topical case or do you need a subtenons? And if the patient isn't behaving, it's only going to get worse. So do a subtenons. If the patient starts moving, You can use a Thornton ring, or you can use your toothed forceps to hold the side port. But I think one of the advantages, again, of using the cystotome is it allows you to top up the OVD until you get a safe flap created, and then you can pull it round and use a second.
Well, sometimes, well, in our case, we usually do use a forceps to hold the eye gently with the left hand with a 0.12 forceps.
Perfect. I just wanted to say that these models, they don't have a cornea, but the important thing is, you can do the incision and then you can understand all that wound awareness we were talking about, okay? So again, you can learn not with the actual real artificial eye, that is what we're gonna use now in the operating room, but here we're learning about all these basic techniques. Okay, guys, so let's go fast because we have the amazing Takashi there. And then, in this experience, in this hybrid experience, the second thing is, come with me, Rafa, if you want. And for those who are listening, we're gonna go to the consult, okay? And I want some tips from the panel, because there, right there, okay, why is that? Certain eyes, are gonna be difficult. We know about white cataracts, we know about intumescent cataracts, but there is something, for example, special. Let's go to that slit line examination. Let's talk to the students how they can prepare in the consults to face different types of capsular rhexis. Luz Marina, I think you also do some kids, and Takashi too. But we can understand and we know that pediatric cataracts will behave completely different, for example. But not only that, even young patients, a diabetic patient, for example, that doesn't dilate that much, that capsular rhexis is going to behave completely. So, to the panel, what do you do, or what we can teach our students here how to behave, or how those vectors in the rhexis are going to behave when you have a very elastic anterior capsule? David, what do you do when you have an elastic capsule?
So often I would be thinking about vision blue, because vision blue can stiffen a capsule. But again, you're looking at how much tension is it under. I'm also thinking what size the pupil is, because I want to give myself the best chance to make what is essentially a hole.
Perfect. No, we're listening. I'm giving some instructions. Go ahead, please.
That's it. And then you just make the flap and pull it round. So I guess your forces are slightly different if it's elastic. So you've got two forces. You've got tearing and you've got shearing. And if you keep your flap flat, you can tear round. But if it becomes elastic, sometimes you need to pull towards the center, which is more of a shear force. And then you can stop, re-grab, and do it again. I don't know if my other panelists would agree.
Well, I also agree with you, but I will add something like when we have a little bit of, think the capsule is a little bit elastic, you have to begin a little bit smaller because it has the tendency to get bigger, the capsular rhexis, if it's elastic. But you have to also be very careful because if you have a small pupil, the worst scenario is to have a small capsular rhexis. So you have to be very sure that you can do at least a 5.5 millimeters capsular rhexis. Always keeping in mind that sometimes you will not be able to see it, but you have to learn to feel it. With time and doing things, you masterize it and your skills improve. And sometimes without seeing actually, because the pupil is, it's a closed pupil or a small pupil, you can feel where you are, you know where you are. So you have to keep on moving your flap in your rhexis as if we do with a handkerchief, putting one on top of the other, and we'll assure a very good capsular rhexis and go on.
Perfect. So in that model, we were talking about wound awareness. But the second thing, and this is very important in the campus, is where we can draw, we have an eye, we can understand all those vectors we're talking about. If you have an elastic capsulorhexis, then when you grab it with the forceps, you're gonna pull to the center in the eye, okay, guys? But in this case, that is not that, it has that tension, you're gonna do the sharing technique. So if you see the screen there, I'm gonna draw you how you can understand those vectors, okay? So sharing technique will be with the forceps grabbing the capsulorhexis and going like that, okay, guys? Can you see that vector there? Yeah. That's gonna be sharing, and for share, the best thing is to put the flap over, okay? And then you can share. When you talk about gripping, okay, it's a completely different vectors. Put it here in red. Well, maybe red is not going to be in the orange, but you can understand you're going to pull this way. Well, basically, we'll make like to the center of the eye. So every time you're doing something, a young patient with pituitary cataract, or that you want to do a maneuver to rescue the rhexis, because the rhexis is falling outside, you're going to grab the forceps with the forceps technique, and then you're going to pull to the center of the eye, as you can see there. Let's put it in blue. Again, to the center of the eye, right? This is called, guys, ripping. Okay, and just to finish, right now we're going to get ready to go to the operating room. But before we go to the operating room, we're going to talk about what the WEBlab is and how the second part of we're going to talk about the second part of the webinar for today, okay? This is very important for all, especially, and it's in Spanish, and you have a QR here for all those who are in Mexico. They can come and train here. You can give us, your contact, and we'll give you some basic courses. And the last thing that I wanted to share you with that is how different type of cataract will have a completely different behavior in a capsulorhexis. In this case, you can see a white intumescent cataract. See, and the vectors are going to behave completely different, as I said. You can aspirate a little bit there, but that rhexis will going to always try to go out to the eye. Okay, look at how many things we can learn from here. There's many. For example, the side of the rhexis is kind of too small, and then the surgeon is not that aware that the rhexis tends to go out, and then he's losing control, and then he did a maneuver, a rescue maneuver, and he pulled to the center, exactly what we were talking about. We were talking about breaking. So the key here is how much we can learn from a video while doing those tests. It's very important. Okay, we're gonna pass now to the operating room. We're gonna use very, very important and a very important structure about how you simulate, in this case, seeing a patient and doing a cataract surgery, especially capsulorhexis. We are preparing ourselves and briefing you what's going on. We're going to have the simulation activity, and very important thing, we're going to have a debriefing. Okay, we're going to see how did you guys feel about it, what can we improve, what can go better next time, and then we're going to evaluate you. And the second thing we're trying to, today is the WEBlab. This is very important, and I hope I did a good job in explaining what the WEBlab is. Just before that, remember the program, guys, the QR. If you want to, start training with us again, we have the QR, but it's all in social media. You can do it but the WEBlab is what we want to do today, okay? We want you to understand this concept. Because of what we're doing with artificial eyes and the micro-ray, we can train with people from all over the world. We did it last week, and we're doing this week with Takashi. So this means that I'm going to be with these students. Takashi is going to be with other students, but those students are going to have mentors from different parts of the world. And actually, if you have, where do you live? A microscope, a microwave, and the artificial eyes, we can train you by distance. And that's the power of technology, okay? The thing is, or maybe you're in a hospital, right? Or maybe you are in your own operating room and want to learn a new technique. The thing here is that technology is connecting us in real time. So you're doing surgery and you're talking with any of these mentors, and they're training you maybe to get your technique better, maybe to do a new technique. Okay, guys, so we're going to talk a little bit about the debriefing, but now I want Takashi to start doing stuff in the operating room, and we're going to get ready our operating room to also do the WEBlab with our students. So Takashi, thank you for being here with us, and thank you for all the effort you did to have, all the technology, and welcome.
Hi, can you hear me?
Perfectly.
Okay. So here, this is Laura. Okay, Laura is third year resident. Okay, I'm gonna show here a little bit of our studio. Okay, so our OR, we're using the micro rack and the Bionicle eye. Okay, and this is a Lumera and a Centurion, and I'm using the Ingenuity to capture the image and to show her steps during the surgery. Okay. So Laura, can you talk about a little bit what we're gonna do?
Yes. Hi, nice to meet you, Laura. So I'm gonna demonstrate it first, just to tell the main incision and the accessory and the capsule was already made. So I'm gonna do the surface and first the hydrodissection and
you can do. Okay. So the hydrodissection. Okay. So here the settings of Centurion is we're gonna do the sulcus with 50% of linear ultrasound and 300 of vacuum and aspirating flow 30. You don't need so much. Usually I recommend between 100 and 150 and a little bit of flow rate, because to be clean when you're doing the sulcus. Okay. So Laura, what are you doing? Let me see.
I'm doing the hydrodissection in some points here.
Oh, sorry. Very centering the image. So we already did the capsular axis, okay? And probably it's about 5 millimeter of capsular axis, right?
Yes, now I'm gonna rotate.
Okay, so she's using a ASICO sustainer chopper. It's the same as you can chop, you can rotate lens, you can do phaco chop, and you can do the counter pre-chop technique with this chopper. Very interesting. You can open incision when in femto laser cataract surgery too. So it's a really good instrument.
So now I'm gonna do the sulcus.
So she's using a balance tip from Alcon, and well, this is the nano sleeve. You know, we have the nano sleeve. Oh no, this is the ultra. Oh, this is the ultra sleeve. Yeah. So we have the nano sleeve and the ultra sleeve here available in Brazil. The nano sleeve is a sleeve for 1.8 to 2.2 millimeters. And the ultra sleeve is for 2.2 to 2.4 millimeters. Okay. Okay, doing the sulcus. So usually we recommend to do at least, you know that the tip has 0.9 to 1.1 millimeters. So if you have the crystalline, you know that the crystalline has a 4 millimeters dippet. So you have to go at least 2 tips down on the sulcus before you break it. See?
So this is already done. So now I'm gonna simulate your shopper.
Okay, okay. So this is the sleeve I was telling. See, it's a little bit orange. Okay. So now she's gonna do she will try to break using the pre-chop. This is the AZCO Combo 2 pre-chop. Okay. So usually she tries to break it. If she doesn't, you know, she starts to do the Faco chop again, the stop the chop again. So this is a kind of a pre-trainment for pre-fractures technique. So they try, you know, they try. This is a good exercise. Okay. So she did the scoping, she did the pre-fracture, she tried to fracture with a pre-chop, and now she's gonna do the chop, the breaking with the chopper and the chopper and with the chopper, right? The faker chop, yeah. So she's gonna break.
Sometimes this
Yeah,
big
you
one
must
twisted.
angle. Yeah, usually has to angle. Yeah, there. Okay. So now she's gonna change for quadrant removal settings. So she's using 450 fixed linear fixed vacuum and 45 aspiration flow and 80% of torsional linear movement. Okay, continuous torsional settings. One thing is very important here is to put the IP, the intelligent phaco, for at least 90 or 95% of the vacuum. So you don't have the clogging effect, right? I see Bionico as a very good artificial eyes because you can see the shaving effect as well. So what are you doing, Laura?
So now I'm gonna do a classification of the nucleus. So try to take this quadrant.
So Laura is our, we have 8 residents per year here, and Laura is the best third year resident in FACO. Right?
I'm trying to.
So it's a big pressure for her. Okay. So all her residents of her year are watching too, so very good pressure, right? See? So here, one of the hits, the pearls is how to hold the handpiece and the chopper very well. You have to stand it better so you have more movement on your hands, wrist, elbows, you know. See, very good. Excellent, excellent. So Laura didn't use the epinucleus. Okay, I forgot. I think she's very excited, you know. Okay, Laura.
Thank you for the invitation. So what I like in here is like it's very close to the human eye, especially of the cognification. That's the one that I think is better for learning. You know? So thank you guys.
Okay, thank you, Ivo. No? Can you hear us, David? What do you think about it?
I thought that was great. There's 2 things I would say. You very carefully said if you know the size of the tip and you know the depth of the cataract, thankfully most trainees are cautious, so they never go deep enough and then they have problems with cracking. So I tell all my trainees 3 deep grooves, and then you're in a position to crack, because the crack is at the back. You need to get at the back. And the second thing I would suggest to your trainee who did a great job there is try to keep your phaco, trust your technology. I try to keep my phaco probe, once I've grabbed that quadrant, it stays central in the safe zone, and I use my second hand to manipulate pieces into it, and the technology should bring the pieces to the tip. If you go fishing with your phaco probe, that's when you grab things you shouldn't. So if you have a proper crack, a proper division, then once you get those pieces into the safe zone, allow your machine to do it. And if you record your footage, you'll suddenly see how much you're moving that tip. Keep it absolutely safe still, and then you'll have no issues. So well done.
Excellent. Marina?
Yeah, congratulations. Very good case, very good patient. Well, I'll say that, we have our trainees, we use the Ultra Chopper. And since the Ultra Chopper has a maximum length of 2.5 millimeters, there's no doubt that there would be any damage to the posterior capsule. But you have one important thing to say for people, for trainees, is that when you take a look at the biometry, you have to measure the length of the lens. You have to take a look at that measurement because it will help you. Many times these lenses are 4.5, 5, or even more. Another thing is that the aspiration holes, you have to also be very aware that the aspiration holes, they should be side to side, not just to protect the cornea, the endothelium, but to help with the technology. As David said, the technology helps us to bring in those all the things that you have to grab, keeping in the safe zone. But very good, very nice.
Very nice,
Thank you.
Laura. Laura?
Thank you so much.
No, we are really happy that we can that people can learn now with these kind of technology. It's really comfortable to see that when we learned cataract surgery, it wasn't like this kind of treatment.
Never.
Right? And I think it's like anything you do, well, you must practice, study a lot, and practice a lot. So I think this is a really game changing for the new generation.
Takashi, I would also say that the advantage of the model eyes is not only can you learn how to do things properly, but you have a safe environment to learn what happens if you don't follow the principles. So if you move your probe too far, if you pull your rexus out, you get to learn the margins of safety and what movements you can and should do or should not do. And that's the big advantage. When you learn the principles, learn how to operate within yourself, not to the extremes of the eyeball.
Yeah,
Exactly.
and the other thing important is that they have the opportunity to receive also tips from many surgeons, because sometimes what's good for you is good for others, and you can adapt more to one surgeon or others. That's also very good.
Yeah, we received from Bionico this week on Monday this new generation of Bionico eyes, and this is the one of them that we are using. And the Bionico, Andres from Bionico, he just told us that this is very updated technology. So now you can do cornea surgeries, you can do sutures, and the incision is better, and you see the capsular rex quality is better and really changed to an upper level.
Mm-hmm.
So really good, really good. Congratulations, Bionico. And the combination of micro rack is always good to learn and to do the streaming for everybody.
And from a resource point of view, just because you've used that eye to practice the phacoemulsification part, you can still stitch up that wound. You can do 24 keratome wounds and 24 stitches, and then use it for a trauma case. And then, so it's good use of the resource because it keeps the costs down.
Yes.
Exactly.
Yes.
Yeah, exactly. And streaming, right? You can learn with the best surgeons in the world, like David, like Marina, right?
Yeah.
And and Lara can learn more, right?
Yes.
So Evo's there. Evo. So I think the next step would be to show, would be talking about the settings, right? Well, could you tell about what kind of settings you use for phaco, for conquer and sulcus, or for quadrant removal, David?
Sure. So I use the Centurion, and I have reduced settings for my trainees. But I'll go back to what I said at the start. The beauty about the Centurion is that it will maintain a pressure within the eye. So if you want to reduce the pressure with your heavy hands, the machine will pump more fluid in to maintain that pressure. So I believe it is much safer. I would do most things with a pressure of 40. The other settings I personally put up quite high. And I'll not go into the numbers of that, but I have a sculpt setting, and then I have a chop setting, which is essentially a high vacuum. And I will make the trainee learn how to use the foot pedal to move on through the different parts. So once I've done my sculpting and I'm happy that I've got movable segments, then I will use my chop either to aspirate and then do an actual chop, or aspirate to bring that piece into the safe zone and then keep my hand still and use my quadrant removal to then go on ultimately to my epinucleus and then my cortex removal. So I think having the stages of why you're trying to do things, I think is very important, and knowing I'm using this to facilitate this movement. So again, we talked at the very start about hands. If you come in from above, I often say to my trainees, if you're going to eat your dinner, you don't put your knife and fork along the floor. You come in from above. So that's how we eat. And that's how you eat up a cataract. And then when you're coming in from there, you learn to pivot with high hands, like we discussed, the piano player. And that allows you to move around inside the wound, inside the eye, and getting that left hand out of the way to do your sculpting, and then getting your phaco probe out of the way to do your rotating is very important, because it will keep the eye in the right position. So, Marina.
Okay. Yeah, thank you. Well, I'll say also that for us, it's very important to set up the pedal, the foot pedal. For us, it's very useful to have step 2 in a wide step 2, so that you're more able to control it in a much better way. So when we have for sculpt settings, since we use the Ultra Chopper, we use longitudinal power, fixed longitudinal power in 50 or 60 if it's a very dense cataract. And then afterwards, something that David said that's very important is that the trainees have to understand why we are increasing this or decreasing that, this and that. Because in some steps we need more aspiration, more grabbing, and in others we are needing, for example, in a sculpt setting, we need a little bit more of power, 50 or 60 longitudinal. And then when we go on to move to further fragments, it depends. If we have a cataract that's not so hard, we can use, for example, the oscil. We put it in, like, say, between 20, 40. And if it's a hard cataract, we'll begin with 50, 40 on, in order to make things more easier and to have less CDE in the eye, that the eye receives less CDE. Okay?
Excellent, excellent. I just want to show here the instruments we used, right? We used the pre-chop combo 2, right? This is the Azico pre-chop combo 2, see? It's very good because it's cut on one side, and the other side that doesn't cut is the one that Lara used, right? And this is the forceps I was telling, the 1.8 millimeters with with the capsulorhexis size. So you can see it fits exactly the capsulorhexis Laura did. See, very good, Laura. What about the instruments you use, David?
So I would use a mushroom chopper. So at one end, there's a chopper, the other end's the mushroom. And I believe that's safe because my mushroom can do lots of smooth things with the epinucleus, and my chopper is very effective. But one of the things I've been teaching my trainee recently, again, if I'm going to do 3 deep grooves to sculpt, if I put my phaco probe deep and push it hard with my mushroom, so I'm not pulling the groove apart, I'm pushing it, then I find that is a great way to get a proper crack at the back of the cataract.
Oh, excellent. Marina?
Well, we use the, when we're making the cracking, the ultra chopper and the divisor in the left hand when we do horizontal ultra chop. And we're going to, when we do vertical ultra chop, we use the sustainer in the left hand and the ultra chop in the right hand, the ultra chopper in the right hand. It requires a little bit more of expertise, but it decreases much more the CDE, and it's very good for really hard cataracts. Afterwards, we use manipulator and the balance tip.
Balance tip. No, perfect, perfect. Okay. Yeah, I think that these kind of, I really am a very fan of ultra chop as well. And I use the sustainer, the Akahoshi sustainer as well. I think it's a very interesting instrument because you can use in all other steps like rotating IOLs, rotating the nucleus. Yes. You can sustain the nucleus, you can break, do the phaco chop, do the divide and conquer, stop and chop, and I think it's a really interesting. I never heard about the mushroom. I really wanted to see, David, one day the mushroom.
Yeah, it's two-ended, so one end has the chopper, and then the other end has a little mushroom at 90 degrees. It's like a little ball. So it just gets you round that corner, but it gives you much more confidence that you don't have anything sharp near the capsule. One of the things I was going to mention as your trainee was operating was the importance of making sure the nucleus rotates. If it doesn't rotate at the start, it's not going to rotate safely later. And what she did really well is if you're doing your hydrodissection, you don't do it directly opposite your wound because there's nowhere for the wave to go. You do it at 90 degrees that side, 90 degrees the other side, and then you can use your hydrodissector to rotate round. And if you inject as you do that, it will hydrodelineate as well, which gives you a safer epinucleus shield, a shell. So that's a very nice technique to make sure it has to spin. If it doesn't spin, you don't get the sculpt.
Can you comment, Laura, your rotation technique?
Oh, yeah. When I start to do the hydrodissection, I take several points.
A little bit louder, please. We cannot hear her.
Louder,
Can
louder.
You hear me?
I think it's the mask.
Oh. Can you hear me now?
It's better. Can you hear her?
Better.
So when I start to do the hydrodissection, I did in several points, and I try to rotate. I have a little difficult, but it goes easy, right? And I finish with the couple of
Yeah.
but not too hard.
Yeah, I think I don't know if the audio is good, but Laura said she did a hydrodissection on all direction, and then she rotated very well. So that would be her technique, right? I usually hydrodissect only one side, and if I need, usually I don't need. Usually I only push the nucleus on the other side to see the BSS coming on the other side. Usually I just perform once. So what's your David and Marina hydrodissection technique?
Well, for the beginners, we have one important tip to give you, is that when you're beginning, you don't have like the idea, like the notion of how much liquid to inject. So you can do a groove and divide the nucleus into two halves before doing the hydrodissection. Why that? It has been proven by Dr. Abarwala, and it has been proven that the moment that you have the highest intraocular pressure is during hydrodissection. It can reach more than 200 millimeters of mercury at that moment. So you divide the nucleus, split it into two halves, and then do the hydrodissection. You're going to have a space in between the two halves so that that fluid can comes out. That helps you decreasing the risk of posterior capsular blockage. And also for the beginners and for the more trained surgeons and for expert surgeons, it's a very good use, especially in polar cataracts, because it decreases the pressure inside the eye when you're making the hydrodissection.
Okay, guys, can you hear me?
Yes, yes, I can hear you, Ivo.
Takashi, amazing.
Yes,
Thank you so much. For matters of time, we're gonna come back here. So again, guys, we did 2-in-1. Okay, we did a hybrid blended education with the virtual campus and the on-site campus here, and now we're finishing this, WEBlab experience. So what we did is we have. Think about it, guys. We have a David from UK. We have a Luz Marina from Colombia. We have a Takashi from Brazil. Here we are in Mexico City, all learning from each other, but not only learning theory, learning by doing, learning by actually doing it, the hands-on. So mixing the WEBlab with what we did in the hybrid campus, right now we're going to go to the OR, right? So another student is going to do the complete surgery. You can see the surgery in another camera, as you can see. I hope you can see it perfectly. And now we're going to, put all those concepts we were talking about into practice, but also understanding that there is a patient. Remember, guys, the patient will move the eye. That's very important. So the eye needs to be centered. The second thing is the wound awareness. And the third thing today we're going to talk a lot about is about the vectors she's creating with the capsular rhexis. And all of that in the image, in the mind, that the rhexis needs to have the correct size and the correct location, okay? So let's start then here. So she did the incision and she put some viscoelastic. And let's come back to that camera to see where the secret happens. Remember, guys, the rhexis happens outside the eye, in that hand position, in the floating, and then you can see both, both cameras. Let's hope that the light lets you guys see that hand position. And can you see the vectors there? So she's doing a great job, and always remembering that you need to have in mind the correct size and the correct location of the capsule rhexis. Perfect. Let's do some, you're doing some sharing and ripping, and that's the important thing because you're doing a decision making on steroids here. You need to, there is no black or white here. There's no sharing or ripping is good or bad. The thing is, you need to do the correct vector in order to have the correct size. And you're doing a great job. And now you're entering the most difficult, place, that is the subincisional. And because there you need to do a very extreme pivot. You need to just go out the incision and then completely change the direction of the forceps and the vectors. Perfect. And very important here, the capsular rhexis is the signature of the surgeon. Everybody's gonna see it in the future. So why do you need to do it fast? There is no need to do a capsular rhexis fast or in 2 or 3 movements. You need to take as many movements as you need to make it very circular, you know, centered and with the correct size, especially now that we talk a lot about multifocals and trifocals IOLs. That's a beauty. What do you think, David? I would like to know then again, going back, you're there sitting in the OR with a student doing his first capsulorhexis. I'm pretty sure your heart is beating fast, but tell me what you do, what do you say to them?
That looks great. I would have a slightly different approach, but I think it depends if you use the cystotome to puncture the capsule or if you use the rhexis forceps. But what I would do is with the cystotome on the viscoelastic, I would get my student to enter the eye in the center, make a slit from the center to the left-hand side and pull towards themselves. That will create a flap. At that point, they can switch to the rhexis forceps, and going anti-clockwise, they will do the rhexis behind the incision first, which gets the difficult bit out of the way, and then you can go round the rest of it easily. What your student did there was great, but you saw at the end, the flap was trying to come out. The excess tissue flap was trying to come out the main wound, which will change the forces, and sometimes it can run out. So I'm a believer in get the difficult bit out of the way first. And I think the best way for the learning student to do that is by making a definitive cut with a cystotome once and pull towards you, not multiple things like this, which just flops up the cortex and you can't see what you're doing. But again, the dry lab, the wet lab is a place to learn the pros and cons of each technique. And you need to know how to use both techniques to get yourself out of trouble. But great job.
Excellent, excellent. What about you, Luz Marina?
Well, we use since the beginning the forceps, the capsulorhexis forceps, and we make a spike towards 6 and then going anti-clockwise. What David says, it's a good idea because, of course, under the main incision is the most dangerous area. And you have to be very aware at that place of not pressing the incision, not pressing. And at the beginning, you try to make a lot of pressure. So you have to be very light-handed. But we do it the way you do it. But I'm going to try the way David's suggesting.
Perfect, guys. So we're gonna have a second student. Let's see if we can do it. Takashi, any other tips on teaching that first capsulorhexis?
Yeah, Laura was saying that her capsulorhexis was better. Yeah, that's a residence learning curve is really good. You know, I think we must always try all techniques. I agree with David. When I started phaco, I was doing with cystotome always. In some cases, I do with cystotome. And I think you have to have on your, ability, all kinds of instruments. So when you have some different situations, you can use them. I think especially when you have like a very shallow chamber, cystotome is the best because you can, like David was saying, that you have more control of the anterior chamber because you can put more viscoelastic during the maneuver. So I think I was telling to Laura, and I'm sure our residents are watching this streaming. I told them that it's really a good idea to have all the techniques on your heads.
Perfect.
So very good, very good.
Thank you so much, Takashi. So, we're gonna have a second student again, and we're gonna do with the flap, what it will be very, very cool. It will be, for example, this time to mix the hybrid classroom with the WEBlab, and why not David can teach our residents how to do a capsulorhexis. Are you up for that, David?
Perfect. One thing I would say,
So we're gonna come close.
I would say before you do that, when a trainee is in the eye, they don't have to do everything. A trainer can start the rhexis and allow the trainee to finish 180 degrees of the rhexis. Next time, 270 degrees. Next time, 360. So you build it up. It's not all or nothing. So anyway, to talk through this, I presume there's viscoelastic in the eye. So what I would do would be a cystotome, but we don't have a cystotome here. So I would go in the main wound and I would puncture, but I'm moving my instrument, puncture and move to the left, unless you have a cystotome.
So sorry, David, you do it clockwise or unclockwise?
So you're going to go in with a cystotome to the center. You're going to puncture in the middle and slide to the left. And then while you're in that groove, you're going to pull it towards yourself. So slide to the left.
Perfect. So center to the left. And this is history. So we are teaching from the UK. You're teaching to Mexico cataract surgery. I don't know if anybody saw something like this before, huh?
And so as you puncture and pull to the left, you should then have a slice, which then will turn into a flap.
And I also love your concept, David, and I am a big fan of it too, about deconstructing tasks, right? I mean, you can do something in the beginning, something in the end. It doesn't mean you didn't get the chance to practice if you don't do 100% of the surgery. And let's be honest, all residents, if they don't do 100%, they feel bad, right?
Absolutely.
So that's very important. I love that concept. What do you think? I can help with that. Let me try to help with that. So you do it to the left.
We do it to the left and then we pull towards ourselves to create a flap, which is coming towards the main wound.
Okay, so let's go to the eye. So you do
in the middle, slide to the left, pull towards, perfect, pull towards yourself.
Towards myself.
Okay. Yeah, pull towards yourself and then we'll create a flap.
Yes.
And once you do that, once you flip it over, you can then stop and grab the edge of that flap with your forceps. Once you get that flap.
Great. So I have the flap. I hope you guys are seeing it. And I'm learning surgery from the UK to Mexico City real time. This is awesome.
So you grab that flap and then because you're going behind the wound, you're pulling it straight to the right. So you're pulling it straight to 9 o'clock. And once you start seeing a stress line, you let go and re-grab. Now you pull down towards the patient's right foot. Keep pulling towards the patient's right foot until you see a stress line, re-grab. Now pull across towards the patient's left foot.
One quick question. You do this because then you are avoiding, right, like the most difficult part, the subincisional in the beginning? Is that your reasoning?
You've kept your rhexis out of the way. It's nowhere near the main wound. Your flap is flat, and that keeps the forces. Now you're starting to pull around towards your own left foot. So you're keeping the flap flat, and you're pulling the flap, not the fold. And so everything is coming around smoothly, and you are not risking new forces with the wrong vector. And you've got the difficult bit out of the way.
Perfect.
Perfect.
How about that? I'm learning the way you do capsulorhexis. With how many kilometers separate us in this special moment, right? Many, right?
Yeah, you'll be a cataract surgeon soon, Ivo.
I love you, David. You know I do. So, guys, thank you so much for the time. I'm pretty sure you have a really good experience, a different one, as we said in the beginning, right? Takashi, thank you so much. David, you know, you're part of the group, as you know that. We love you from here. And Luz Marina, thank you so much again. Thanks, everybody. You know, all the students are here with us. Thanks also to them. And we're going to keep doing a lot of surgery. And here's the important message, guys. everybody. Now technology is allowing us to learn cataract surgery from everywhere and to everybody. So everybody who is committed, right, to become a cataract surgeon, we're gonna be there to help you guys. So hope you have a great time. There's a lot of people that are gonna see this, in a different hour because everybody's working, but we're gonna keep doing this. We're gonna keep teaching people how to become not only cataract surgeons, but next week, we're gonna do strabismus, we're gonna do cornea, we're gonna do oculoplastics. So stay tuned, and thank you very much. Thanks to all the panel for being here with us.
Okay.
Thank you.
Thank you.
you. Thank you very much.
Thank you very much.
Lara?
Bye bye. Thank you.